right, Evan the Counselor Live. This is a live show. This is going to be a podcast. This is going to be up on YouTube and many other of my socials. So today we're going to be talking about diagnosing. And a little later on, we're going to have a friend and colleague, Dr. Brent Haagensen. He is a clinical psychologist and one of the smartest dudes I know, and he is a specialist in diagnosing. So I'm going to bring him on, and that's an area of interest for me. I'm a bit of a diagnostic nerd myself, and we're streaming live mainly on TikTok right now. So we got about 45 people, which is awesome, who are watching. And for those of you on TikTok, we're going to move to my TikTok cam. I really would love for you guys to stick around if you're interested in this topic. I'm going to be turning to you guys periodically to see if you have any questions at any point. If I miss the questions, I'm sorry. It's going to be a little harder now doing this, but keep asking them. You can ask it multiple times. That's fine. This is a very serious live. That is correct. People are saying this is serious. It is a very serious live. I got 3 cameras. I got 3 lights. I've been futzing around all morning trying to make sure these microphones. This is the second time I'm doing this. So, yeah, I think it's going to go well. First time went well. This is going to go even better. We got a guest. So, all right. So, let's start off. So, I have a sponsor. How cool is that? So some of you know, like in some of my videos, I have that bull painting, El Toro Rojo, in the background, and people would ask me all the time about that painting. Where did you get it? And it was just something I found when I was buying my new house. I just wanted some really cool artwork. So people ask me about it all the time, and a whole series of events happened, but I got hooked up with them and the artist who does all these. And so they just sent me, I'm so fucking excited. My followers know this. I got a new piece here. They sent it today from my office. I don't know if you all have the same taste, but I think that's awesome. It's called Fire Dance. So it's Vibe Interior, VYBE. And if you put a code EVAN40, you get $40 off. So that's Vibe Interior if you want your place looking super awesome. If you want all your friends to be jealous when they come over, they're going to think you're an interior decorator and should have your own HGTV show. But no, you just went to Vibe Interior. That's awesome. Yeah, thank you. It is a beautiful piece. I am super, super excited about it. So now I have El Toro Rojo. I have the Fire Dance. I got 2 more coming in. So that would be super awesome. So another thing before we start getting into the nerd topic, we are going to, I want you all to shoot me an email if you can. It's evan@evanthecounselor.com. You could do it through my website, on my link tree, on my Insta, but just reach out somehow and give me your email. And I will shoot you over a copy. So I'm writing a book right now, and I've been using this with my clients for a long time. I keep adding to it. It's called The Communication Formula, and it's the guide to dealing with difficult people. So it's a pretty fun book. It's short. It's like 100 pages, but has a lot of practical advice, whether you're working in customer service, mental health. It applies to a lot of different situations and personal situations. So it's the first 25 pages, about a quarter of the book, I'm giving away as a free sample. So the other thing to note too is I have a Patreon. Links in the bio on my link tree as well. So if you go on that Patreon and you sign up at any level, you get the full book. So at any level, you get the full book, all the way up to doing a coaching session with me once a month. So again, someone's asking, the email is evan@evanthecounselor.com. Usually I'll have something in the background of my lives with that, but it's going to be a little difficult now. When this comes out on YouTube, you could hear it, but you could also just go on my Instagram, DM me on Instagram. Yeah. Oh, we got the Nerdy Therapist. What's up? Thanks for joining. So yeah, we got 57 people. That's freaking awesome. So this is perfect for our live stream podcast here. So yeah, so reach out to me, just get in touch with me, shoot me your email, we'll get you that book. It's super practical. I guarantee you'll find it helpful. Maybe not, we'll see. But yeah, most of the people, I gave away the first 100 copies free. So we got to do a little testing, and I keep updating it, and so I'll send you updates as they come, especially if you're on Patreon. What's up, Ellie? Ellie's one of our top tier favorites coming from Chicago. That's awesome. So what else? Yeah, so again, we have a guest coming on the show, Dr. Brent Haagensen, and the topic today is mental health diagnosing. And it's confusing as hell. And I'll tell you what, probably a lot of therapists get confused with some of the elements of it too. So if you're confused about mental health and diagnosing, that's fine, I get it. All right, I just got an email sent. That's awesome. And also when you get on my email list, I'm going to send out periodically some like helpful information, some like stuff I do with therapy whenever I go live. So it's about like once a week, so I'm not going to bother you too much, so you don't have to worry about that. So yeah, we got that going. What else are y'all saying? All right, so Dr. Brent Haagensen, we're talking about diagnosing. So before he comes on, he'll probably just stroll in whenever. I told him like 20 minutes. I'm going to go through some of my own experience with diagnostics and just give a little background and share some things. And I'll periodically look out for some of your questions. So yeah, I'm glad y'all are here. So mental health diagnosing, right? So I mean, we all know about depression. We all know about anxiety, right? These are some colloquial terms. But actually, there's no such diagnosis as depression. There's no such diagnosis as anxiety. Now, that's not to say that that's not a thing, right? We have depressive disorders, we have mood disorders, and major depressive disorder would be an example of depression. Generalized anxiety is an example of anxiety. So there's multiple different anxiety disorder, multiple different depressive disorders, and so the question is like, why do we do it? And it's kind of complicated.
I didn't get that. Could you try again?
Yo, Siri, who asked you to chime in? Maybe we could ask her. Maybe she knows something about diagnosis. So, whoa, what? You have MDD? Yeah, so major depressive disorder. So that's a depressive disorder, right? So we could call that depression. We could call that anxiety. But as you start to get really nitty gritty, and this is one of the reasons why we do diagnosing, and we'll talk about one cynical reason. One is if you want to bill your insurance, if you want to get reimbursement, if this is to be treated like a medical issue, we have to put a diagnostic code. It'd be kind of nice if there was a checkup code where you didn't have to put a diagnosis and get reimbursed, but unfortunately you do. So example, in my practice, we do some assessments for people who get DUIs. Not everyone who gets a DUI has a chemical use disorder. So that's why we charge out of pocket for it, and we tell people to do that because maybe they don't want it on their record. People want to use their insurance, but they don't realize that if you're going and you're using insurance, you're probably going to have a diagnosis on your record. Now, that kind of sounds bad because you're like, it's on my record, it's on my medical record. Now, unless you're like going to be applying for the Air Force or the FBI, I don't know how much that really matters, to be honest. But and that kind of freaks some people out, maybe life insurance, I don't know. So I mean, sometimes that can affect it. So people get freaked out. So you do have the option, if you want to see a therapist, you could ask them, hey, I don't want any formal diagnoses on my record. There is also an ethical obligation, right? Because if we're looking at, this like a medical issue, like a biological medical issue, and it is a little more complicated than that, I would argue with mental health. I mean, there is this element of, if I don't know what the problem is, if we can't at least have a definition of the problem, then what's the solution? So anyway, for everyone chiming in, we're talking about mental health diagnoses. And we do have a psychologist coming on in a little bit who's going to answer some questions more about like in-depth psychiatric testing. So stick around if you have diagnostic questions. All right. So that's one of the reasons why, a couple of the reasons why we diagnose. One is to get reimbursed by insurance. Most people who come to me for therapy, they want to use their insurance. And I mean, that makes sense because these services could be really expensive, $100, $150 a session. Can anyone else not hear me? I just want to make sure. Someone said they couldn't hear me. Maybe you got to turn your volume up. So one of the reasons insurance, the other reason, we got to figure out what the problem is. Now, let's talk about the strengths and limitations of diagnosing the way we do. A lot of you have heard about the DSM-5, and that's this giant fat book with all these different diagnoses that we use. Now, how we diagnose is basically each one is a list of symptoms, right? Just like if you had a form of cancer or something else, there's a list of symptoms that make up a structural diagnosis, right? Diagnosis. And so each one of these has a list, and there's criteria. It's like if you meet 3, if you meet 5 out of 7, it's diagnosable. You meet the criteria, therefore I could bill for it. Now, as we know, human behavior is complicated. We don't all fit neatly into these boxes, right? So I think there is a good argument to make that, a lot of people, it will generalize, right? Generalized anxiety disorder, right? It's not the same use of the word, but it would generalize that a lot of people could say, hey, I'm experiencing something that resembles this. Not every anxiety is going to be the same, just like not every course of cancer is going to be exactly the same. And now that we're doing more brain scans and fMRIs and things like that, we're learning about, that you could actually see these things on a brain scan, the electromagnetic, the way our neurons are firing, different areas where there's overactivity, like let's say with schizophrenia, overactivity in certain parts of the brain that causes hallucinations and delusions. You can see these things. So it's not a perfect system, and people are complicated. And then the question is, what is like pathological, meaning kind of part of your makeup, and what is situational? And does it even matter, right? Because like I said, you have situational depression, maybe in your brain it's going to look the same as a major depressive episode. I think it's sometimes important to differentiate these things when we're looking at it from a problem-based perspective. But how much does that matter, right? So there's a lot of different reasons. So it is kind of controversial. And I think people like to hate on the DSM, but at this point, it's the best system we got. It's not perfect, and I think, there is some merit to it, and there is some research behind a lot of these disorders too. Why don't we pause for a sec? Does anyone have any questions so far about diagnosing or mental health diagnoses, how it's done, why we do it? So feel free to chime in there. Looks like this computer's running a little hot. Looks like, let's see how these cameras are doing. We got camera 2. That looks good. For whatever reason, camera 3's got a lag. We don't like that. Why are you lagging, bro? Do I dare unplug it and replug it in? I don't know if it's recording like that, so we'll see. But yeah, DSM being updated. Oh, that's a really good question. So I don't know how often it happens. It's like maybe every 15 years. So I think there's a big lag in between. And I was thinking about this earlier. I feel like it should be updated more, as we're learning more, as more research is coming out. Is it normal to feel intimidated after receiving a BPD diagnosis? Yes. That's a tough one. Receiving any personality disorder diagnosis is really hard for people. So I'm not sure, because I think people take it personally. Personality disorder, right? It's like there's something wrong with me. And I think there is a possible that we could have a better model for doing it. So I think, so I think people do take it really personally with BPD. Any personality disorder. So I think that's totally normal. Do you think BPD will be classified as a trauma disorder? That's really interesting. I don't know if they're going to ever reclassify it. I don't know if that's on the docket. I think it would make sense because I really view it more, with personality disorders, I kind of go back and forth on it. I sometimes think, it does make sense, but a lot of times it is a reaction to trauma. It's a reaction to your environment. It's a way of coping and dealing with your environment. So it definitely is a thing. It's a pattern that a lot of people will have. But at the same time, I think there are some problems with it. So you could easily classify it as a trauma-related disorder. If you look at some of the symptoms of PTSD, a lot of BPD is it's like a cluster of those symptoms. So not everyone with BPD with PTSD has BPD, but probably a good amount of people with BPD have some kind of trauma-related disorder, but they have a little bit more sensitivity. They're more predisposed to develop that kind of coping reaction. There's that. I may try to plug this camera. So someone had a good question about what is the difference between a therapist and a psychologist. So do I dare unplug this? Just unplug it. Just do both of these here and see if that works. So yeah, what is the difference between a therapist and a psychologist? And, all right. This thing is still lagging. What are you going to do? We'll hope it chills out after time. Time after time. So, okay, difference between a therapist. Okay, actually I shouldn't even say that. A psychologist is someone at a doctorate level. A psychologist could be a therapist. A psychologist could be other things. A forensic psychologist. They could be a researcher and not really work with clients. And you could have your doctorate in psychology and then not get a psychologist. So it's like a license, right? So for me, I'm like a master's level clinical social worker. I'm also a therapist. The only thing I can't really do that, let's say, Brent could do would be in-depth psychological testing and psychometrics. So, they go to a little bit more school, maybe a decent amount more school, so they could do that. But a lot of them just end up being therapists anyway. So it's just a different discipline. Like I have my LICSW, Brent has his LP, you have an LMFT. So it's just these different letters behind your name. It's the licensure that you work under for your state. I think I saw another question in there, and folks were asking, and this is great, is how long does a diagnosis stay on your record? And this is where I think we could have a better idea of diagnosing and what is more ethical, because you could have a diagnosis in remission, right? So you could have a period of depression, you could have borderline personality disorder, and if you do a treatment for it, theoretically, right, it should be able to get better and then not have it as a diagnosis anymore. You could say in remission, you could say a past history of, just like if you had a torn ligament and that heals, now you no longer have a torn ligament. So it really shouldn't have to stay with you forever, but sometimes it is relevant if you have a history, because then you're more vulnerable to have it later. Any other questions here? You found my FYP, the Tinder girl who accidentally replied to your roommate's ad years ago. What? That's interesting. You applied to my roommate's ad. I don't know what you're... That's so funny. What other questions? In my fibromyalgia support group, nearly all people have CPSD. I don't know much about it, but just from a personal observation, I observe the same thing, that people who have something like fibromyalgia definitely have a trauma history. So if you told me that if they came out that there was a strong connection, I would not be surprised in the slightest. Hormone imbalance, medical conditions affect mental health diagnosis. Yes, I think a lot of times it is important to rule out some of these diagnoses through medical, right? So there are a lot of different medical, and we're learning more about that. And sometimes when you treat that underlying condition, then you no longer have those symptoms. So hormone imbalance is a really good one to rule out first. And it's easier, to come see me for therapy. I'll give you an example. I had a client who had a really bad stomach virus. I think it's called H. pylori. Wiped out her gut flora, and we're learning more about gut health and horrible anxiety. She would see me every week, never had anxiety. She was older, maybe almost 70, never had anxiety a day in her life. And then all of a sudden, she, it was some of the worst I've ever seen. And, our sessions were productive, but it was so physical. There's only so much that could be done. Eventually I kept telling her, go to the doctor, and she would, and they just wouldn't really take her seriously. But finally one doctor did. They put her on a stomach medication, and it just got so much better. And for her, before that, anxiety then turned into addiction because of Xanax, and then alcohol when she got off the Xanax. But that was one of the most clear examples I've seen. As a patient, can we ask that our therapist not diagnose us? Yeah, that's a good question. We talked about that a little bit earlier. So you can ask them that, but you got to pay out of pocket, right? So when I do coaching with folks who follow me, and we'll do. So I don't really see people for therapy who follow me on TikTok and stuff like that, but I will do coaching, and that's all out of pocket, right? That they sign up for my Patreon, so we don't have to do anything with diagnoses. I could help in some ways. I do have some boundaries there with mental health, but But yes, you could go to therapists and pay out of pocket and say, I don't want a diagnosis on your record, and most of them will probably oblige that. Yeah, so they won't put it in your official record. Now, but if you're using insurance, you have to. Yeah, you won't get reimbursed otherwise, and a lot of people don't know that. And so I've had people kind of come back upset later, like, oh, I didn't know that. Well, it's like, well, that's the only way. Just like if you go to the doctor, I mean, there's a checkup code probably, but for mental health, there's no checkup code, and I wish there was. But insurance is not going to pay for anything unless it's like, an actual diagnosis or disorder. Refuse to work publicly. So should we avoid therapists who refuse to work publicly? So I'm not sure what that means exactly. Like insurance or Medicaid GP codes. Oh, no, I don't think so, because here's the thing. I did that like choose your therapist, and I joked about the private practice or private pay only snob. And there's nothing wrong with taking private pay only. Here's one of the reasons why you could have some sympathy for them is insurance does not make it easy to get contracted with them and credentialed. So therefore, like, it's a huge process. It could be really expensive. So some people just say, hey, I can only do private pay. And that's one reason people do it. The other times it's like when people are like rock star therapists, or they've been building a practice over years. They have a good reputation. They don't have any problem getting clients. So then they just do private pay because it's difficult to deal with insurance. You have to have a lot of infrastructure, business-wise, billing staff. It's not easy. So I understand why people do it. But I wouldn't necessarily, shy away just because they don't. So if you went to therapy, you're going to have a diagnosis on your insurance records for sure if they bill insurance. So, yeah, there's that. What else? Do you believe in... I'm not sure what that means. Oh, we have a special guest. As I promised before, we have Dr. Brent here. So here, let's get us set up. So yeah, if you want to grab a seat here. So we got about 33 people on our live stream. Excited for you to come in. So here's the deal. So our TikTok, our live stream folks are here. Unfortunately, there's like a lag in this camera. So I don't know. Well, it doesn't really matter. So here we have our TikTok live stream, as you can see here. So if we're talking to folks on TikTok, it'll be in that camera. Well, right there.
Sounds good.
And then here we'll have us recording. We'll use the front cam. That looks actually pretty good. I was a little worried. We got some water for you here if you would like. Yeah.
Thank you. It's great to be here.
Awesome. So yeah, if any of you have questions, feel free to chime in. We'll be checking periodically. So I thought a good way to start is, who the hell are you?
Well, I'm Dr. Brent Haagensen. I'm a postdoc resident in psychology at the moment. My training is in psychology, a doctor of psychology, pursuing licensure as a psychologist.
Can everyone hear Brent okay? Yeah, make sure to speak up. I don't know.
I'll enunciate.
Yes, very
My
good.
undergrad degree was in music, so I can make that happen.
Oh, maybe, yeah, so maybe we could convince Brent to sing just a little bit. At the end, if you stick around, that's an incentive to stick around, is Brent will do a little barbershop quartet. Maybe we'll do one together, we'll see. All right, so yes. Okay, so go ahead, sorry.
The work that I do now is primarily in the field of kind of an outpatient clinic, where I do probably about 3/4 psychotherapy and 1/4 psychological evaluations. And kind of in that setting, it's outpatient. So, do we get some questions coming in?
Yeah, they're going to be coming in. So here, let's do this because you're kind of getting covered by the question. So here, if we do this, yeah, now they could see you better. It's just on your chin sometimes.
Sure.
Are you a tenor? People want to know.
I am, yeah.
You could hear in his voice he's a tenor. What am I? I'm a baritone. No,
you'd be a baritone.
I'm a baritone. Yeah.
But it depends. Sometimes you can be bisexual. So.
You could be
bisectional. Right?
Bisectional. Okay.
Multiple different sections you can sing in. So.
Oh, that's impressive. But. All right. So yeah. Okay. So you're working in an outpatient. You're doing therapy. So like the topic today is diagnosing. And I mean, this is a topic I think a lot of people are interested. We have like a lot of good questions, and I've answered some of them. But people have been asking us like, okay, does this diagnosis stay on my record? A lot of people don't know that like if you're billing insurance, there has to be a diagnosis code, and that it's similar to the medical system, for better or worse. So I think a lot of people aren't really made aware of that. People are wondering if you have a TikTok. I don't believe you do.
I don't at the moment. We'll see how it goes.
We'll see how it goes today. If you all are nice to him, maybe he'll consider doing it. So people have been having those kind of questions. So we kind of went over diagnosing. Now people are going to be coming in and out, and this is going to be recorded too. So so people can go back and watch the entire thing. So how did you get into the field?
Yeah. Well, what was really interesting is. I had wanted to be an attorney, and so I had taken the LSAT and kind of gone through that process of going in that direction, and discovered, I went to work after I graduated college and discovered that I really did not like wearing a suit and going to work from 9 to 5, which was probably going to be what things looked like in that area. And so I kind of switched gears a little bit. I wanted something that involved communication. I wanted to help people. I wanted to be able to kind of work within people, right? There's working between people, there's working within people, and I like kind of the prospect of helping people explore kind of what's going on, because I think that's fascinating when we do it with ourselves too, kind of going through this process of learning and growth, which I was going through at that time too. And so it kind of began by pursuing a master's degree in counseling, and throughout that process at the school that I was going to at that time, there was a doctorate of psychology, which was also offered, and decided to go down that road. So
awesome, very cool. So you're going to be an attorney and turned therapist, two very kind of like similar but different. What are the similarities, would you say?
Well, I would certainly communication. I would say advocacy as well. Right? When you're an attorney, as when you're a therapist, you owe your client fiduciary, right? Which is you are working in their best interest.
Mm-hmm.
I would say that working in a client's best interest in therapy probably doesn't involve the same degree of perhaps manipulating the legal system that might come in when you're an attorney.
What about with insurance?
Well,
people have been asking about that a lot, and yeah.
Well, the insurance system it's tough. We're sort of there's so many different theories of psychotherapy and psychology, and many of them don't even conceptualize what's going on with people as an illness, right? A lot of the experiences regarding mental health are normative, right? It is normal to experience some degree of anxiety, some degree of depression, life adjustments. And so to have to kind of fit what some people conceptualize as normative in terms of this is a diagnosis, right? This is an illness, right? This is a disorder. The book that we use is called the Diagnostic and Statistical Manual of Mental Disorders. And so to have to kind of navigate that system in order to get compensated by insurance companies so that people can get care is sort of, you do have to play both of them. So maybe I take it back. You do have to do some of that in terms of manipulating that
play the game a little bit.
Go ahead, yeah.
Well, yeah. So, and just for everyone tuning in, we got Dr. Brent Haagensen. We're talking about diagnosing, so answering people's questions about diagnosing. So feel free to ask any questions. We're recording this live as well for a podcast. So you're talking about like manipulating the system like a little bit. I mean, we don't have you on record saying you do that, but sometimes you have to work within the system to try to find the best way to meet the client's needs, because a lot of people can't afford to pay out of pocket, and that's what people are asking too. Is, well, can I ask my therapist not to diagnose me? And I'm like, well, one of the ways to do that would be paying out of pocket and asking them and making sure that they're okay with that, and coming up to that agreement at the beginning. But also it's interesting, and I mentioned this earlier as well, talking about the situational forms of depression, anxiety, or how it could look very much the same versus maybe pathological, but like more, biological and recurring for some folks, where some people it is maybe more of like an adjustment disorder type thing. And I did a post, it was funny, like a week ago, it was like a joke about someone going into the therapy store and asking, like saying, hey, I want to do therapy with my insurance, but but I don't want a diagnosis. And then the guy behind the counter says, hey, try adjustment disorder, and kind of like with like a wink and a nod, like, oh yeah, it's real, we just won't tell anybody, right? So you have that called adjustment disorder. But would you say that like those things, like, what would you say the differences and similarities are of someone who has situational depression and someone who has more recurring biological depression, even though they look the same? What would you say? How do you view that?
Yeah, well, so having, as I said earlier, having any response to something significant that happens in your life is normative, right? So one of the bigger differences, I think initially kind of discriminating between what might be sort of an adjustment disorder with depressed mood versus what might be a single episode major depression diagnosis can be difficult sometimes. The adjustment disorder would be more, we would go in that direction when there is some major life change in your life wherein you might expect to experience some degree of distress that's associated with that change. So that's when people have a breakup, when people lose their job, when people maybe move sometimes. And I think the difference too, what has to, to meet that criteria is that it might be kind of a little over and beyond what maybe the average response might be, and so that would fall into that adjustment disorder category. When we're talking about a kind of a major depressive episode, that's going to include criteria of not being able to enjoy activities you used to, kind of persistent sad mood over a defined period of time. That also includes experiences of hopelessness. There's also physiological symptoms. You can have sleep difficulty. You can have slower motor movements, difficulty getting up in the morning, right? So that's going to kind of go in that direction. The difficult thing, which I think this whole conversation of diagnosis is that to some degree you might go to one therapist, you might go to another therapist, and they might diagnose you with completely different things, but they're going to agree that what you're going through is depression, and that services are going to help deal with that depression. So they assign some diagnosis or some code as a means of just allowing you to start getting services. And oftentimes what I do, particularly kind of in an outpatient setting, working with folks where the initial session, it's supposed to be a diagnostic assessment. Now that's just not always possible. When folks come into therapy, they're like, hey, I'm going to tell you my story because I got stuff going on, right? And it is not therapeutic as a therapist to like sit there and ask all these very specific questions and criteria, which in many ways can be kind of assuming this expert role, which can be unproductive. And so in those situations, if I know we're in the depression area, I'll say unspecified depression. Right? And
then kind of go back and change it later when you get a better idea.
Yeah,
it's really tough because you do have, especially if you're billing through insurance, you have to put some kind of code at the beginning, and it's really hard, to get. I always view it as like a snapshot in time when somebody comes in. It's like, here's where they're at, but also taking into consideration their past, their situation. Trying to get so when I do like a diagnostic assessment, the first questions I ask are, I try to make it like more conversational, like, okay, well, what brings you here? Tell me more about you. Where are you from? And then I start to get a little like deeper and deeper as they start to warm up a little bit. Do you have like an approach for that first session?
Yeah, when folks come in, I do kind of my informed consent.
You try to speak up a bit. I think people are having a little trouble.
Absolutely.
There we go.
Right.
Can you hear
I'll
me?
speak up and enunciate a little bit.
Why don't you move you up
sure.
like a little bit too?
You can go like that. How's that?
Come like a little this way, so maybe try to get some of these letters out of your face. Look at that. Yeah.
So in terms of kind of that initial approach, I do the stuff that I'm required to do, which is to say who I am, what my credentials are, limits of confidentiality, which is to suggest that I'm mandated reporter in terms of any sort of abuse or neglect of a child or a vulnerable adult, or imminent danger to themselves or others, or in the event of being subpoenaed by a court. Right? These are also some of these logistical things that happen in that instance, but under the vast majority of circumstances, it's a confidential space, and so I set that up. And then I oftentimes say, I'm going to have a bunch of questions for you, but right now, please tell me what's bringing you in today. How can I help you? And oftentimes when folks are coming in for the first time, they're doing so because something is going on, and they have a story to tell, right? And so giving them that space to do that, I think, is a strong start.
Yeah, awesome. Yeah, I totally agree. Some questions. Let's do a quick one here. So, do ADHD, depression, and anxiety link together?
Well, they certainly can. There's an awful lot of what we call, there's comorbidity, which is diagnoses which happen at the same time. Right? You can be diagnosed with ADHD, anxiety, and depression. There's differential diagnoses, which would be how do you separate between what might be a symptom of this and what might be a symptom of that. So difficulties with attention and irritability, hyperactivity, restlessness, those can be anxiety symptoms. They can also be sometimes depression symptoms if there's sort of like a difficulty with sleep difficulties can fall into that category too. Also, if you're depressed and that's really suppressing you physically, if that's impacting your life, you may have a considerably more difficult time focusing, right, with what's going on. So there's certainly a link. There are kind of certain markers that we sort of look for when I do psychological evaluations. We do a test of continuous performance, which is a computerized test, and that measures your attention and response control. So attention broadly is can you focus on what you're supposed to when you're supposed to. Response control is can you inhibit impulsive responses at times when you're supposed to as well. And in those circumstances, there's going to be different profiles for what someone might look like in terms of anxiety and what someone might look like in terms of ADHD. So for instance, kind of anxiety, someone's difficulty with attention, oftentimes when they start a task, they have a tough time paying attention almost initially, right? And they have to kind of find some sense of balance and comfort. And when they do, they can then sometimes sort of perform that task in a stronger way. Louder?
Oh no, go ahead.
Okay, and in an ADHD profile, sometimes they may start strong, and then the performance is going to kind of taper off as the task continues because they get more fatigued. Their capacity to maintain a high degree of attention might be depleted by the end of that task.
Mm-hmm. So, someone's just asking, can't those computer tests be inconclusive, especially for ADHD?
Totally. Which is why you would never diagnose based exclusively on a computerized test, a test of continuous performance. What I do as kind of a component of my battery is just a word for a bunch of different tests that you put together for something, is I do a cognitive test, so that's to measure kind of IQ and cognitive profile. We do a personality inventory, we do a test of continuous performance, and then a couple of different measures of executive functioning, so that's other tasks of planning, organizing, being able to switch between tasks is a big component that can also be a measure, an indicator of ADHD. So just that you wouldn't, and then also inventories which require collateral information, which is another piece required for an ADHD diagnosis. Is there evidence that these symptoms existed prior to the age of 12? If there is, great. In circumstances, particularly with adults, if they don't have access to that, then we kind of do the best we can. But at the very least, we want to have someone else in your life who knows what this looks like for you to fill out one of these inventories too.
So getting like the importance of that collateral information.
Absolutely, right, and because that what can be difficult about this system is that oftentimes ADHD, or at least historically before there's a couple different ways to do ADHD. Sometimes if folks go to their pediatrician at a young age, their pediatrician might have them fill out one of these inventories and have their family fill out these inventories and then send them on their way with a prescription. And sometimes that can be effective, sometimes it's not. But generally speaking, anyone that thinks they're having attention concerns is going to meet to have enough symptoms to qualify for that. But the piece with any diagnosis in the DSM is that it can't be better explained by another disorder, by the use of a substance, or by a medical condition. And so by being able to look at these different domains, what might be anxiety, what might be depression, is there adjustment, is there something, particularly when I look at a cognitive profile, And tell me if I'm getting into it too in depth here. But
no, you're good. There's a couple of good questions coming in too that are relevant.
There's kind of a typical ADHD profile, which is going to be strengths in verbal and nonverbal ability, so puzzles, words, and then weaknesses in terms of working memory and processing speed, so stuff that you can hold in your brain at once and how quickly you can scan through stuff. And that is kind of a typical ADHD profile. It's not the only one. But that...
Do you do ADHD testing?
Mm-hmm.
Oh, you do?
Yeah,
okay.
That's actually probably the majority of the referrals that I get is lots of individuals struggling, particularly this year, where we have kind of everyone shuffling between different academic situations with distance learning, and which requires a lot more visual demands in terms of visual attention. And so there's a lot of folks saying, do I have ADHD? And some of them, yes, it's sort of revealed impairments that's maybe already existed. And for other folks, not so much. What they're actually going through right now is we have not been able to adapt to this system necessarily so much.
Sure. So yeah, for people just joining in, we have Dr. Brent Haagensen. So we're talking about diagnosing. So we're going in depth. So if you have any questions about mental health, diagnosing, and this is also being recorded too, so this will be up on my YouTube. So feel free to subscribe to that, and you'll be able to watch the whole thing if you can't hit everything today. So that's going to be my next question, and somebody did ask here about what is. Can you go into more depth? Maybe just an overview of psychometrics and psych testing.
Sure.
And when is that appropriate versus just going to a therapist for a diagnosis? Maybe just a brief overview of that.
Yeah, well, that's a real broad category in terms of psychological testing. So psychometrics is the word that we use in terms of kind of the math of psychology, putting data together in terms of psychological tests. And what that includes is, generally speaking, taking individuals from different categories, so we would say kind of a normative population, so individuals without symptoms, and we're going to give them all of them a whole battery of tests to see what that might look like, and then kind of comparing that in different diagnoses. And so if you have within a normative population, or within a sample population, you're going to have 1,000 people diagnosed with generalized anxiety disorder, 10,000 people without any disorders, and so on and so forth. So that that's how the tests are designed. So that when I'm giving someone now an MMPI, which is kind of gold standard in terms of personality, it's the Minnesota Multiphasic Personality Inventory. There are pretty strong profiles and indicators for what certain disorders might look like, or at least the symptoms of that kind of a typical profile. Now, to the second component of that question, which is when and where, I think it kind of depends. It generally starts with, do you have something going on? Have you seen a therapist, right? So you maybe start there, or maybe it's the doctor, right? You start with your physician, and they're not entirely sure in terms of medications. They're not entirely sure in terms of diagnoses. Yeah. So that differential to you're struggling in school, but also you experience a lot of test anxiety. Is this anxiety? Is this ADHD? Is this a specific learning disorder in a certain domain? So being able to kind of look in, and if you want to discriminate between a couple of different diagnoses, that would be one approach to going in that direction.
So you're a therapist, right? And like similar to me, you have someone come in. How often do you, and you're also able to do psych testing, which I'm not, so how you have that tool at your disposal, and I could always refer to someone like you to do it. How often do you do psych testing with people who are just coming in for therapy? Like, what's your kind of cutoff line?
Yeah, there are different, there are certainly, when it comes to having, so it would then be a couple different roles there. So if I'm going to do psych testing with someone that I'm doing therapy with, it is because it's going to inform the treatment plan and the recommendations for the work that we're doing in psychotherapy. Generally, if it's something else that they want to explore, I would then refer them to someone else. My role when I'm doing psych testing is often as a consultant. Someone has referred them to me to do psych testing to explore for a certain diagnosis or to rule out a certain diagnosis. And when I'm doing therapy, I'm usually the primary provider in therapy. But there are a few times, kind of a handful of times where I've been working with someone for a while. I feel like sort of the relationship that we have and kind of the understanding that we have in terms of the goals, this is going to really inform that if we have a better understanding of what's going on with someone's cognitive profile. And so I might then do some of that testing myself, and that falls into this category of sort of therapeutic assessment. That's using assessments as an intervention in therapy. I would, in terms of numbers, I'm not sure. I would say maybe 1 in 25 folks I see in therapy at some point or another, I suggest maybe you get an assessment. Let's figure this out and rule out certain things to make sure we know what the best direction is to go for.
For sure. Someone's asking, do you feel pressure to give a diagnosis ever?
Well, it is a standard, within our field that Evan talked about earlier in terms of, in order to get insurance compensation, in order for insurance to cover this from a client standpoint, we have to use a diagnosis. I think it's a little bit more than that too. If the concern is just the label of a diagnosis, I totally understand that. If the concern is data or having a third party like an insurance company look at your case notes, then those are the things that I just recommend we talk about. Right? How much do you have? What are those concerns? So that sometimes I show my psychotherapy notes to clients, right? And it can be what's required for a note is why did they come in today? Briefly, what was the content of the discussion? What was the intervention that I used? And what was the client's response? That's what's required. And so that can be as minimum as a client presented for therapy to address depression. Writer used acceptance and commitment therapy diffusion techniques to discuss intrusive thoughts in the past week. Client responded well to the session. Right? And
do you have private notes too that you keep? Do you keep a private record and a public insurance record?
Yeah, well, you can. I don't, but you can. You can have notes that are required in that domain. You can also have your own psychotherapy notes. It is important to note that at least from the that sort of rare concern that something could be subpoenaed by a court, those psychotherapy notes can also be subpoenaed too. And so if you have concerns about that, talk about your therapist, talk to your therapist in terms of what is kind of your practice. Some people have take notes in session. I don't. I think from an ethical standpoint, kind of my practice is to just have kind of bare bones minimum.
So someone else is a therapist only as good as their notes.
I think no.
It's probably very little.
Right. I think it can go both ways. I have excellent therapists who keep very, very diligent notes. I think a therapist might. There are other things that would contribute to that. I feel like I have a pretty strong narrative memory, right? So when folks come back in again, we can pick up right where they were because I have a pretty good idea where they came from. Not good with names for whatever reason, but that's not a concern in my area. But if I remember what's been going on with them, I don't necessarily have to write that down. But that's just kind of my perception. So I think it's kind of everyone has their own area of strengths and areas of growth, and leaning into those is what's going to make someone a good therapist.
For sure. Yeah, I totally agree. How do you prepare before seeing a client?
Deep breaths. It depends.
Depends who it is, right?
It absolutely depends. There are certainly differences in terms of. It would be a lie if I said sort of difficulty and stress level when it comes to sessions. If I'm working with a high conflict power couple in marriage counseling, that requires a lot more of me.
Yeah.
And I think it's equally necessary, and it can be equally rewarding, but it's very different than someone who's coming in who what's effective intervention for them is to have someone do some active listening and some reflection so that they can explore their own thoughts in a deeper way. So the preparation kind of I don't have a standard way of preparing, but it definitely it depends on the client, certainly.
For sure. Yeah, I totally agree. Absolutely, it really does depend on the client, and sometimes I think for me a gold standard as well is, and it's maybe a little easier now that everything's on the computer, but to look at the note from last week and remember if there's any assignments that I gave them. I think even if it's just like a brief look, and kind of being able to recall, recognize what we did last time. All right, so I can only go so long before we talk about some of these things because people are asking these questions. Like A Silva, I've been seeing what you've been asking. Okay, so Since you're newer to the mental health world and social media, there's some things that you need to know. Now, there are some topics that are, I just wrote down 4 topics that are by far the most talked about and that people who are interested in mental health are curious about. Now, I'd say a lot of people who follow me, most people are just maybe folks who have struggled with mental health disorders themselves on and off through their lives and have gained an interest in it, or their family members are just generally interested in self-improvement. You have other people who work at, a good percentage of people also work in the field. So here are the topics, and you've already started to see that are the most talked about. All right, ADHD, trauma, BPD. Probably number 1 is narcissism.
Oh, is it? Okay.
It is by far the number 1 thing people want to talk about. There are accounts that are fully dedicated to this topic, and people love it. So it's like in personality disorders in general, I think BPD, and I think a lot of people, just from my observation on here, have struggled themselves with BPD, and a lot of them have come out the other side. But yeah, a lot of people who are interested in mental health are people who have sought out mental health, or mental health services have sought them out. Mm-hmm. So a lot of that, and right with narcissism, folks, try to present as having it all together, more functional. Everyone else is the problem besides them, so you don't quite hear their stories as much. But you hear maybe more with BPD. So let's just start with the personality disorders. Why do you think that's so popular? As I bring it up now,
well,
now that you're learning.
I would suggest that it's so popular because personality disorders they're more likely to fall into this category of chronic, right? One of the diagnostic criteria for personality disorders is concrete and inflexible, like this sort of personality presentation that someone presents with. And I would suggest that, this is just a guess, of course, but I would imagine that this is a popular topic in social media because people's relationships and their lives and their emotions and their families are affected so deeply when someone's mental health is concrete and inflexible, and particularly with these diagnoses that, relationships and how you interact with other people is part of the criteria. Borderline personality disorder, narcissistic personality disorder, antisocial personality disorder. Or even the opposite sometimes. Mm-hmm. We're talking about a schizoid presentation, which is individuals who are, really don't need interactions with other people. They're not so much interested in that. Or, kind of a push and pull type of dynamic. Here,
you turn up your volume.
I will turn up my volume, yeah.
So it may be fading out a little bit.
Yeah, but there's a push and pull, individuals with avoidant personality disorder, which is like it's social anxiety, turned up to 11 is really what it is in every domain. Mm-hmm. And these are things that just affect people's lives in a chronic, deep way, maybe more so than their experience of anxiety might. And that is a speculation as to why that's popular in social media.
So yeah, and so many people who are on here, and maybe it is because a lot of people report here, and it makes sense that let's say people who have BPD or maybe in the more emotionally vulnerable tend to attract narcissists, or if you look at it from an attachment perspective, the Romeo, it's the dismissive and the anxious. Like peanut butter and jelly, like a magnet, kind of attract each other. And I think a lot of people, the more it's talked about, I think people self-diagnose their loved ones with different personality disorders and that kind of thing. And I would say it probably makes sense that a lot of people have narcissistic traits, maybe really toxic in relationships. How much of that do you think would be actual pure NPD? What's the prevalence of NPD from your perspective, and what are some other explanations for someone having toxic or narcissistic behaviors?
Yeah, well, I don't have the Diagnostic and Statistical Manual in front of me, but I'm pretty sure the prevalence of narcissistic personality disorder is about 1%.
Yeah, it's 1 to 3.
Right?
If you looked on here, it would be 40%.
Right. But the criteria, what's difficult with narcissism, or at least from a diagnostic standpoint, is that the criteria, they're individuals that kind of fit this personality template of narcissism have not so much self-awareness. It can be very difficult, in the awareness of how they present versus what their internal experience is, which is often, I'm not good enough, I'm scared, and they present to the world as I am better than, I'm going to sort of put down someone else's strengths because I'm insecure about my own. And so maybe to slightly segue, what came up when you brought this question too was also, I think we do a disservice by stigmatizing personality disorders. I see folks come in with really stormy interpersonal relationships, a history of suicidal ideation and self-injurious behavior, and really fragile sense of self-image. They kind of split their presentation when they're in different situations, and they have diagnoses of anxiety and social anxiety, depression and post-traumatic stress disorder and obsessive compulsive disorder. And it's like, well, they have borderline personality disorder. Let's just name it, right? There's really effective treatments for that. Dialectical behavioral therapy is one of the most effective treatments for many mental disorders. Let's just name it and work on it. The difficulty then is, are you working with someone who's in a place of kind of acceptance and growth in terms of that, which is an issue when it comes to diagnosing in the first place. Is some people are very intimidated by having a label attached to them, and other individuals really start to
empower.
It
can be empowering.
Just
like in our world too, Brent and I both work a lot with addiction. There's that kind of controversy of like the label of being an alcoholic. Is that damaging? Is that empowering for some people? So I think that is something to be weighed, and I think it depends on the individual. I think it's how you frame it to them as well. I
would say it also depends on the developmental stage that someone is at in terms of dealing with what they're going through. So someone who's using this example of addiction, someone who's walking into a treatment center for the first time, and people are saying, "Hey, I'm an alcoholic." That may be overwhelming. That may seem that's ridiculous. You're suggesting that I have some sense of a weakness. You're applying this label to me. Whereas someone who maybe has some years of sobriety and has gained a sense of self-awareness and improved relationships, having gone through their own program of recovery, may really proudly say, "Hey, I'm an alcoholic, and that means X, Y, and Z, and I'm a better person for it." So I think kind of that, and people may go through different developmental phases in terms of how they choose to identify what they're going through.
Yeah. No, that's really great. And I see that there's these narratives that come up online, and I do see them as being damaging, right? Where some people you have some people who like view BPD and have dealt with someone like it, and it's stigmatizing. But I think what's happening a lot is folks with BPD are being looked at as the victim. And a lot of times they have been the victim of a lot of trauma, and then people with NPD are the victimizers. And it's the only mental health disorder, and again, I use that term loosely for probably a lot of what's going on here, but people view NPD without compassion. People have words for it like narc. You see that like, well, how do I deal with narcs? I mean, literally, it's probably the number one thing that I've seen. What would you say to that about like having compassion for someone with, or like an antisocial person? Even like the narcissism one gets hit even harder than like the psychopathy on here. Like, what's your thought on that?
Yeah, what can be difficult in that situation too is perspective and being mindful of the task, I guess I would say. And when I say mindful, I mean, can I look at the high-level situation? Because oftentimes what can get wrapped up when you're dealing with someone who presents with narcissistic traits is that we get triggered and we get pissed off. And that can be true with anyone that has, kind of a disorder which is really interpersonal, right? It's how they interact with the world, and it can be frustrating in that way. And so being mindful of what am I trying to accomplish in this situation, in this conversation, what's important to me in this relationship, can be really important. And then, I think it can be very difficult when narratives arise as this person's a victim and this person's an aggressor. Whereas, generally speaking, most of these, well, there's all kinds of different theories on this, But I oftentimes subscribe to the school of thought that many of these interpersonal disorders, personality disorders, kind of originate in terms of early interactions with individuals who were not kind to them. And they didn't necessarily learn the same coping strategies. They didn't have the same degree of affection. They may not have the same types of resources. Whereas that sort of fragile sense of self kind of emerged from that. And they developed certain patterns which have allowed them to thrive. That's how they learned how to cope and be successful. So that's interesting, being kind of new to this, to hear that maybe that they're framed in that way. Because sometimes I hear it the opposite, Well, I don't know that I've ever heard narcissism really framed in a positive way, so I'll agree with that. But sometimes borderline personality disorder can be really equally stigmatized as these.
I'd say in the
really
field,
tough to deal
I would
with.
say in the field, I'd say NPD stigmatized, but I could only think maybe of a few examples of someone who I really viewed as having that NPD, kind of that would meet diagnostic criteria, that maybe has some of the antisocial traits that's very pathological and likely has a poor prognosis for I can only think of a bunch, whereas with BPD and maybe that's just how many we see, whatever, and I know and people like to argue with me on here. It's well, that's just because they never get help. But I know that when we look at prevalence studies, you look at collateral. You don't just take their word for it. I mean, there's other ways, and maybe it is more than what we would think it is. But with narcissism, I kind of view it personally. It's we have a healthy level of narcissistic traits, right? And part of it too, we live in a narcissistic culture that values money, fame, whatever, and we get rewarded for it, positively reinforced. And then you have a second level, a tier of maybe folks who, in a situational, trauma environment, maybe they're in a situation where they're a famous person, right? And then they keep getting reinforced, and they're not pathologically, but they're just everyone does everything they want them to do. They get just rewarded for that. And then I view the top tier of the NPD, where maybe there's that mix of antisocial traits, and people, and that is more rare, but maybe that would be more the pure narcissism. What do you think?
Yeah, well, I would suggest that it's probably not more rare, but it's more adaptive, would be my opinion. Individuals with symptoms of narcissistic personality disorder who might go to certain lengths in terms of manipulating other individuals to accomplish their goals. Sometimes that's what businesses do. For better or for worse, right? You can probably be effective in a non-symptomological way with having traits that qualify as narcissistic personality disorder. Whereas if you have suicidal ideation, storming relationships, and sort of a diffused personality and dissociation, which you might experience as a result of borderline personality disorder, you might be considerably more likely to seek services for that. So we're probably going to see that more often in a clinical setting.
Someone was asking, let's say you did have someone come in, what would you do to treat that individual who had NPD full-blown, or just that was really their pattern of coping?
It starts with modeling, right? Which would be skill-based modeling. Let's start to institute some communication patterns which might be more effective. So someone's presenting to me because something is going on, right? Then it is kind of within my my responsibility then to let's look at what are the goals and how are we going to address those. So if that's if it's someone who, and oftentimes it actually comes out like this, what their experience is anxiety and depression, and what might be emerging is some type of narcissistic traits. Then part of that modeling is we're going to establish boundaries in psychotherapy that are going to demonstrate to this individual what effective communication and relationships might look like. And so if someone is trying to, beginning to exhibit some of these manipulative behaviors as a means, well, then it's going to be establishing, what would be a good example here? Trying to dictate when we have, I don't know, to some degree trying to establish sort of their own control over a situation, right? It would then be my responsibility to kind of name that, to set a boundary around that, and kind of move forward in a productive way. It's a lot more easier when it comes to someone well, I shouldn't say easier. It's still very difficult, but there's more of a template that exists when it comes to, or a standardized template when it comes to borderline personality disorder. When we just start going through different modules of dialectical behavioral therapy in terms of learning to be mindful of your emotions, learning to address crises, which we call distress tolerance, taking care of your emotions on a daily basis, and learning more effective ways to communicate with other individuals.
So yeah, someone's asking with BPD. One of my closest followers, Jen here, she's asking, can BPD show up when you start your teen years?
Sure. Yeah, absolutely. Well, I think BPD symptoms oftentimes are going to emerge during that period, but it can also be reactive to trauma. There's some research that suggests that personality disorders have a genetic component to it too. But I think it would make sense, right? Kind of when you have sort of, the developmental tasks for a teenager is to understand what am I good at and who am I. And so if in this period of time when you're trying to you have this emerging identity, to have some of these symptoms come out at that period of time makes a lot of sense.
So I've always viewed it, it's just like my observation and maybe based on some like learning research, whatever, but it's like, we're born out of the box with certain personalities, right? That a lot of it like actually is biological. I don't know, maybe 50-50, right? It's like and I tell this to parents sometimes, there's like they have two kids that are raised in the same set of circumstances and they are completely different. Their personalities emerge, just like having a puppy, like only so much of it is like what you could control. But that certain folks that say have BPD are just naturally maybe a little more sensitive or a little bit more emotional. You could start to see some of those traits a little bit, but then like any mental health disorder I view as like a susceptibility plus stress equals diagnosis, trauma, whatever that stress is. So that folks with BPD, they're just kind of naturally, it's like their personality, they're a little sensitive, maybe a little overwhelmed by emotions. There's good parts about having that personality and maybe not as much. Add pressure, then you have, this, like I view it as this coping pattern, right? And therefore that trauma is a big component. People were asking me that earlier, is like, should this be classified as a trauma disorder? And maybe the same thing with narcissism, right? Maybe that's kind of your personality a little bit more, and then whether it's modeling, whether it's stress, trauma, then that gets expressed in this problematic way.
Yeah, well, there's two questions in there. The first one being kind of the etaology, or where do some of these symptoms come from, and the second one being how should we classify it? Kind of from the where does it come from standpoint, I think you and I would agree in terms of you may have a genetic or biological susceptibility, which then combined with the experiences that you've had and an invalidating environment or an environment which has perpetuated those behaviors and those coping strategies, that may be how you then learn to get your needs met, right? If I don't threaten suicide, people don't think I'm serious, right? That people may have over and over again and have those symptoms reinforced. Or people may have had, really, really traumatic experiences where, which have sort of caused them, and this is sort of that trauma conceptualization, to form different neurological patterns where they might dissociate. And is that then dissociative identity disorder? I think kind of to the second question, though, of how do we classify it, that becomes more difficult, right? Because maybe we are treating trauma, but when someone presents with the symptoms of borderline personality disorder, the work that we're doing is we are then addressing that susceptibility to emotional responses and how you deal with individuals in an interpersonal way. So it's tough. You may do trauma work, but oftentimes the modules that are effective for those is we're targeting those specific symptoms that have emerged from the trauma.
For sure. Yeah, absolutely. And that's another thing, one of the big ones, and I think I'm not as excited about the narcissism thing, if you can tell, but like as far as trauma, and one term people use all the time right now, I'm trained in EMDR, I'm trained in brain spotting, like I consider that to be one of my specialties. And obviously there's childhood PTSD, complex PTSD, simple PTSD, but yeah, people use that CPTSD, complex, so like, I was surprised when like people kept, I'm like, what are you referring? Are you referring to complex? And some said childhood, but sometimes, that is traumas building upon each other. And someone had asked like way earlier, and I was curious to your opinion. And I think this does go to the like strengths and limitations of the DSM of like, let's say sexual compulsivity is not in there. You have to bill under something else, right? We know this is a thing that people struggle with, and it's very controversial. But so, for example, should complex PTSD be its own diagnosis in the DSM? Or maybe it could be a qualifier under PTSD.
Well, I think there are certain categories, diagnostic categories in the DSM, which we have a better understanding of, and some that we don't. And I think the fact that we have acute stress disorder and post-traumatic stress disorder pretty much as the only trauma diagnoses is probably not accurate. That said, and maybe this is slightly controversial, I can put that diagnosis down, but then the work that I do ends up being tailored to the individual that I'm working with anyway, right? So after I put that diagnosis down, and obviously this is dependent on how important it is to the individual I'm working with, but I care much more about who they are and what their experiences are and what their symptoms are than the diagnosis that I have to assign for this, for logistical purposes. So if we had more diagnoses that better fit that from a conceptual standpoint, I think that would be great. From a practical standpoint, I don't know that it would affect the work that I do all that much.
Yeah, that makes sense. It's like, how detailed do you want to be? Is that a specifier? And I think there is a major difference between complex and treating simple PTSD and what your treatment approach would be. Is that necessary for that to be in there? Because, hopefully you're a therapist and you're competent, you're going to treat them a little bit differently. What do you use? I don't know if you do like, EMDR is a really big topic. I did a series on EMDR, and people, because people, a lot of times like the videos I do, or like when I'm in lives, people ask me these similar questions, and EMDR walk me through, and then eventually I'm like, I'm sick of explaining it, just go watch my video. But so I did like a 6-part series on it. Anyways, what do you use? What modalities do you use when you have someone with PTSD, CPTSD trauma?
Yeah, well, so they all fall into, and this may be slightly controversial too, but most of them fall into a category which is exposure-based preventions, which is, or interventions, which is you are then, excuse me, to some degree, this trauma has been encoded in your body, when it happens. And within that too becomes the trauma responses, so PTSD has kind of these 4 categories, right? There are the re-experiencing symptoms, there's the negative symptoms, there's the escalated symptoms, and then there's the what's the other one? But anyway, they're broad categories.
Dissociative. And,
there's the dissociative symptoms,
like the mood and cognition.
That's the negative cognition, and then the sort of the hyper-reactivity in terms of
mood,
hypervigilance, increased startle response. And so those are kind of encoded in the body, right? And so when something is triggered that reminds you of that trauma, these responses are automatic at that point. And so the theory behind exposure-based therapies is when you then kind of face, to some degree, that experience, and your body, it kind of reactivates to some experience, and there's different ways to do this. So EMDR, there's theories that, in terms of kind of the bilateral stimulation that occurs at that time helps kind of open that gate a little bit too. But most of these interventions it is exposure, that once you face this, once you kind of re-experience it, but again, you're not re-experiencing it as the person with the same sort of vulnerabilities that you may have had when it happened to you. You're experiencing it in a safe environment with a certain degree of coping skills associated with these different interventions, and you're experiencing it as a person in a safe place with someone to help process it with. And so there's a lot of different interventions when it comes to that. The ones that I like to apply are kind of narrative-based trauma interventions, but I don't do real complex trauma work with individuals who are just coming in for PTSD.
Purely that.
What I often see is that folks come in with some anxiety or even like an adjustment disorder, and it's like, well, this is related to maybe X, Y, and Z that may have happened in your childhood, right? A repeated pattern of an invalidating environment that has, that does trigger some of these trauma symptoms. And so we then actually go back and let's do some exposure-based interventions in that area to decrease the intensity of those triggers and those responses that are happening in the present day.
For sure. And just a reminder, everyone, we have Dr. Brent here, and he is a clinical psychologist. We're talking about diagnosing. Close enough. Shh, don't worry. No, I'm just kidding.
It counts. I'm a doctor of psychology. I'm a postdoc resident there at the moment.
Close enough. Okay, so what else? Okay, so yeah, and that's interesting with the exposure element, and I kind of view it some similarities, right, with like anxiety disorders as well. Like, is it exposures, especially for severe anxiety disorders like OCD, I've used them as like the tip of the spear of anxiety, right? It's just really extreme, and like some of the most tried and true methods are that gradual exposure. And I tell
exposure and response prevention for OCD.
And I tell clients too, it's like, kind of where the magic happens, where you use coping skills so that you could stay at the edge of your comfort zone, not break it. That could be damaging in session, right, for anxiety. But then it's like a balloon. The more you stretch it, you don't want to snap it, but the more you stretch it, the wider your comfort zone gets, the more comfortable you are, and like the bigger your world gets. And I see something similar as well with like people who stuff their emotions, right? They, it's like with the intrusive symptoms, the more you push something away and stuff it down, the more it doesn't go away, maybe just temporarily. And that's a lot with PTSD, even borderline personality disorder, is like means of avoidance. Yeah. So I think, so I see exposure being, an integral part of a lot of the work that we do.
Well, and I'd expand on that to suggest that this whole concept of exposure and all these, there's lots of name brand interventions in psychotherapy. And there's also a concept of common factors, which is, there's lots of different data on it, but something between, 60 and 90% of what works in psychotherapy is the connection, the experience of vulnerability and empathy and the trust that exists in the psychotherapeutic relationship. And I think having that then fosters this safe place for people to experience those, to really start to process these experiences which have kind of been ingrained in their body and affect them on a daily basis.
Do you have a type of therapy, whether it's a brand name or general category, that like is a theoretical orientation for you?
It kind of varies. I would say that what I tend to gravitate towards is something called acceptance and commitment therapy, which is based on kind of this theory that what we're doing is not reducing symptoms, we are increasing individuals' flexibility to increase or to experience symptoms, what's going on, and live their life at the same time. And what I mean by that is, I referenced it slightly earlier, experiences of anxiety and depression are normative to some degree. They become impairing at a certain level, but that's not necessarily uncommon either for individuals at certain points in their life to be impaired by some of these factors. And so what we're doing is we're not necessarily trying to, we're going to get rid of your anxiety. We're going to, can you name and become mindful of the experience that you're having and the role that it's taking in your life, and also engage in certain types of committed action that moves you towards your values and those things that are important to you at the same time.
And then therefore maybe decreasing, like someone was saying, so not a cure, but I mean, my guess is, and I'm just starting to be exposed more to ACT, but it sounds like being able to tolerate that, but then, so it's like, I almost think of it in my head as like, instead of, like, the more you fight something, right, sometimes the more like emphasis gets placed on it, almost like a Chinese finger trap, the more you like pull at it.
One of the examples in ACT.
Is it really?
Yeah,
okay,
Yeah, well, and so it's about cognitive flexibility, right? And there's a bunch of different kind of modules within ACT, but one of them is this concept of diffusion. And so there's this theory that we become fused with our thoughts, and what that means is when I'm experiencing depression, and I start to think that that I'm a depressed person and I will always be depressed, then I am fused with that thought, right? I think that it's always going to be that way. Instead of, so from an ACT perception, we would be working with someone to say, you're experiencing depression right now, right? What is this depression doing for you? What is your depression doing for you, right? And so we would, from a language perception, you're separating that experience of depression from the person. You're not a depressed person. You are experiencing some mood symptoms today, right? Sure. What does that teach you about what's important to you? How can we kind of move in that, in a direction that is meaningful to you? So.
For sure. Yeah, that's an awesome way of looking at it. And I'm looking forward to getting trained more in that as well. I downloaded the Ptsd I don't know, it's like 16 hours. So
Right.
I'm an hour into it, or maybe
Well,
a couple hours into it.
And the concept of kind of fusion is that pain is normal. Like people experiencing pain is normal. And that, so there's kind of an equation in ACT, which is pain plus avoidance is suffering, right?
Mm-hmm.
Pain plus acceptance is, what do you think it is?
Healing.
People always think it's like serenity or healing or something.
Oh, wait.
Pain plus acceptance is just pain. You know, you're experiencing pain and you can handle pain, right? Suffering is paralyzing,
tolerating.
right? You can learn to cope with and manage pain and have a life worth living. Whereas if you're suffering, if you are real concretely living in what you're experiencing.
Well, it sounds like then a lot of your energy then, pain plus like avoiding it, it's also fighting it, right?
Yep.
It's taking energy to avoid it. It's taking energy to fight it, whereas that energy could be placed elsewhere. If I accept that some of these things, like some parts of depression or like BPD, for example, you can heal from maybe almost fully. But then I also think of like maybe the application of like chronic pain, where there's certain things like where you do everything you can, but there's still going to be that pain. So instead of fighting it or trying to avoid it or just sit in it, just to learn to accept it and then put your energy and focus elsewhere, and even finding a different type of purpose in your life, just to live a better quality of life with it, right?
Can you name and honor and sit with some of your experiences and live a life worth living at the same time?
Yeah. Okay, so there's one other topic I wanted to get in with you, if that's okay.
Mm-hmm.
And for everyone just joining, we have Brent. He is a doctor of
psychology, currently working as a postdoc resident. I'll be licensed as a psychologist probably this fall.
Yeah, so Brent, when we're talking about diagnoses, when I knew Brent agreed to come on, I'm like, well, this would be the best topic, because I view Brent as someone who definitely an area of interest, someone I would definitely defer to, especially in more complicated cases. So, so the last one is pop culture and personality. So, right, a lot of, again, with narcissism, but like also people, and especially maybe like millennials or Gen Z, right? We really love things like the love languages, Meyers-Briggs,
mm-hmm.
right? Any kind of like these different measures.
The Enneagram
horoscopes.
Is
Enneagram is big.
People talk about.
Do you think there's any validity to things like the Meyers-Briggs or the Enneagram? As someone who's like really deep into the super scientific.
So that goes back to this word psychometrics, which was thrown around earlier, which is the sort of the math and the science of creating psychological tests.
Mm-hmm.
So something like the Myers-Briggs, it's not based on, so we're getting way into the weeds here, but something called a factor analysis, which is you throw all of these things in and the computer breaks everything down into different domains. So the MMPI has 10 scales on it. Those were created by a factor analysis, these different factors. There's depression, physical symptoms, emotional vulnerability, antisocial behavior, all of those, right, are factors. The Myers-Briggs is not, right? For instance, it is based on Jungian archetypes. So Carl Jung had kind of these different theories of how personality is faceted, and it kind of goes in that direction. So there is some psychometric validity to some of these tests, but the way that I see them functioning as like these different channels for individuals to experience, to start to relate and continue their journey of self-discovery, right? I think it's perfectly legitimate to explore. Well, you don't need a whole lot of psychometrics to think that the love languages are probably helpful to understand, right? Or what your how you identify, right, is really important. So I think that when people come to me really interested and fascinated in these different areas, what that tells me is that self-discovery and learning who they are and how they fit within kind of their sphere of influence is really important to them. And so if it's meaningful to them, it's meaningful to me, and we can go in that direction. So,
have you done those yourself, like the Myers-Briggs or Enneagram?
Yes, I've done them both. I don't remember. I think in the Myers-Briggs I might be in INFP.
You're an F?
Maybe. I don't know, right? Clearly it means more to you than
I
it
think
means to me.
Well, did you read the description after? Did you identify, like, did you think, like, oh, I'm just kind of, like, I think it's true, or I'm like a horoscope, I'm picking out what I think about myself?
Well, the tough thing about that, too, is that, so the Myers-Briggs is based on a binary model, right? So you are this or that, right? And so you fill out X amount of questions, and if you're one tick into the introversion versus extroversion, you are an introvert, so you then fit that profile, which is, I don't think that's necessarily accurate, whereas psychometric tests are based on T-scores, so it's your comparison in a percentile rank to the population that demonstrates that trait, which ends up being more accurate.
So would you say, though, like, maybe it would be more accurate for someone who, like, better fits, like on the further end, like someone's very extroverted, they're very thinking minded, and then maybe they would identify with it more than someone who's kind of like in the middle of these things?
Probably, yeah. And I think there is validity to these tests in terms of what they tell people and how, and these profiles. Of course, there was validity to the work that Carl Jung did in terms of advancing psychotherapy, and it might just not be necessarily as psychometrically valid as certain other tests. So
she. Jacqueline, she's been here, so let's see. Jacqueline, Therese, perhaps we're just going to call you that for now. You've been here like the whole time, so that's awesome. She's been throwing out a lot of good questions. Aren't all therapists, like we're looking at it from the Myers-Briggs and F, some more feeling-minded than thinking-minded? I always view you someone as like, so like one of my most popular posts, actually the post that got the most views as I did, there's a lot of TikTok trends, so we got to like indoctrinate you into these. But there's one where they take the theme music from Super Smash Brothers, and it's like, choose your character, and then like people drop with like whatever you want to put, choose your waiter, like whatever, and then like they drop in and they're like whatever. So I did one like, choose your therapist, right? And I joked, and I had like, the wooey, like Janet the wooey who wants to just do mindfulness and like healing, and then you have like the hardcore like social worker who wants to like fight the system. And then I had the logical psychologist, Dr. Finkelman. So it's kind of like, who do you fit in? I had some other ones too, but I've done a couple versions of these that people thought were funny. But yeah, I kind of viewed you like, people ask like, are you more of a Finkel? Oh, and then I have Chaz, the like the recovering alcoholic drug counselor who's like been through it all, So it's like, maybe view you more as like a Finkelman, but you also have like a very emotional side too. And I've seen you like work with clients. Because you're very like academic kind of guy. So
I think it makes sense to fall into that F category. I think again, and maybe this is my own bias as anything I said today is in many ways, but it's both. If I don't have the thinking and the feeling, then I'm not going to really be doing excellent work. I mean, particularly when I do psych evals with someone, the data tells me a lot, and that's in a thinking place, and let's use that and let's explore, and what does that mean in terms of what's coming out in that area. But what's most important to me, and maybe this is why I fall into that feeling category, is what does this mean in terms of the person's life? What does this mean in terms of how they experience the world, and their thoughts and feelings, and what I actually find fascinating about psych evals is that, again, folks come in because they have a certain set of symptoms which is bothering them, and usually they leave because I've identified some strengths that they weren't even sure that they had. And being able to kind of have a better understanding of how they think and feel and how their brain works, and hopefully some more self-efficacy and confidence moving forward, not just to understand and treat the symptom, but them holistically, who are you, how does your brain work, how do you think and feel, and how can we go in that direction?
Sure. And answer your question too, for my Myers-Briggs, I'm a T. I'm one of the rare T therapists, but that doesn't, again, it's not
I
like...
also don't remember, so I could be wrong.
We'll get Brent tested here, we'll do, And it's one of those things, like, I find them to be fun, like, with horoscopes, I don't believe it, but I've read some things, I'm like, damn, that does kind of sound like me. But with like the Myers-Briggs, for whatever reason, it just like nails me to the wall. I'm just like, fuck, that's like, and I couldn't like read, and there's other ones that are close, and I'm like, yeah, I could identify. And I play this game with folks who have never done it before. What I'll do is like, I try to do like a little experiment where I'll have them take the test, but then not read any of the description, and then I'll take that description and I'll take just random other ones, and then at the end I'll read them, like the general gist of it, and then I'll have them rate it. And a lot of times people will pick the one that they most identify, and it matches up. So I'm like, you know, and you think too, if so many people have taken this test, and there's some of these like sites online that like aggregate the data and ask people questions based on, and like after a while, if you have 16 categories of personality, you'll probably see some patterns, right? Versus like the horoscope, that's just...
I'll buy that. I think then people, well, it goes both ways, right? People may see themselves in this, or people may then, it can be kind of a self-fulfilling prophecy to this is who I am, and this is how I'm going to act. I mean, there's sort of so I'm familiar with Gestalt Therapy, which is really kind of looking at the different facets of who someone is. So from that, you know, when someone dreams, what piece of themselves is being, you know, kind of, are they resonating with about that dream? Same thing with a horoscope. If somebody really resonates with a horoscope that I'm working with, that's awesome. Let's talk about it. It means because it brought something out about them that's true.
Yeah,
what I think is dangerous is then assuming that that's all of who they are, right?
Yeah, and putting them in that category, then they therefore act as if...
That becomes the self-fulfilling prophecy.
Yeah, what about the Enneagram? And then that one kind of has more like more like a clinical vibe to it. I don't know the history of it, but
I'm not as familiar with that. I did take it once. I don't remember what the results of that one were.
It's super interesting.
But I also know a lot of therapists that find it like really interesting, and it kind of what can be cool about some of these tests, particularly, you know, a Meyers-Briggs or an Enneagram, is that people can take it online, right? You don't have to go to a psychologist and get evaluated for it. At the same time, you may not be getting the same product between which program, you know, which Enneagram assessment or which Myers-Briggs assessment that you're getting, whereas if you go to take an MMPI with a psychologist, it is going to be standardized in terms of what that profile looks like. So, I think they're really important therapeutic tools, and I think it could be dangerous for people to kind of then define who they are based on those results.
Sure. Okay, so with COVID, are you able, what is psych testing, deeper psychometric psych testing, what does that look like virtual? Are you able to do that? Are there some things you can and can't do?
Yeah, there are a couple. I mean, for instance, so, I don't know, I think I can tell you what this test looks like without breaking any, but anyway, so there's really interactive components to, say, the IQ test that I use. And that requires putting some puzzles together, that type of facets. There are tests that you can substitute to not necessarily have to use those subtests, but then when you do that, you are kind of changing the test a little bit, and the more you do that, the further away it can be to then apply your profile to the norm. That said, I do have a couple colleagues that do kind of virtual psych testing, and I think this has actually kind of moved the field forward a little bit. So for instance, a test of continuous performance on a computer can be done virtually, as can taking personality inventories. It can be sent to their email, and the results come back to me. What can be tough then is that their home life is not a controlled, standardized environment. Whereas, say, if I'm giving someone a test of continuous performance in a clinical setting, I know the exact amount of volume and visual distractibility that's happening, right, and that can be controlled, so I can apply those in that situation.
I never thought about that.
There's also kind of the factor of, we have, based on different environments, we may have different feelings. So when you're at home, if it's an invalidating home environment, or you're constantly stressed at home, and that's why you're getting tests for ADHD or whatever it may be, you may not be performing your best in that environment. That may not be the most effective environment to see what your baseline is. But that can go the other way too, right? If you're getting tested in like a really sterile psychology office, maybe that has some of those effects too. But I think you can at least control for it more in that way. But I think there are some advantages to being able to do so. I do in office, as I have with masks, and everyone in the office has been vaccinated for a while now. But I have colleagues that are doing it.
How literally, because for a lot of people who don't understand, right? You fill out a whole bunch, you do different tests, and I know it's maybe going to be different with like IQ versus some other tests. I guess I have questions about that too, but how, so then you send all this info in, right? And a computer does some modeling and sends back some narratives, and I've seen them before, but then you interpret it. How much can you rely on what the computer's model? What's the personal, individual, therapeutic element? What you know about this person that can't be deciphered by a computer when you get these narratives back? How does that work?
First of all, there are different report types that you can get. I never get an interpretive report from an MMPI. I just get the score report, right, which is the elevations. Okay. It doesn't tell me what it means. I then go to
the Milan though.
No, I don't get that either. You can get an interpretive report.
So what do you get? You just get like bars of measures.
You get elevations on scales, which is what those tests do.
Okay.
And then, but to some degree, I'm then going back to the same resources, which have a couple different, interpretive manuals for those profiles. And at this point, I have, written out different, in the MMPI we call it code types, right? So there's, elevations in X, Y, and Z code or whatever it may be tend to indicate these sets of symptoms and personality characteristics. What I then do to that question is after that paragraph on what that might mean based on kind of the normative sample, I apply what does this look like in terms of what I already know about the person that's presenting and their symptomology? Does this kind of validate that? Does this reveal some new information? And then it can always be like a really effective therapeutic tool too to take some of these questions and bring them back to the client and say, you answered this to this. What was that looking like too?
For sure, and to give the people what they want, right? If you're assessing for narcissism, right? Would the Milan be the most indication, or does MMPI have any indications with?
It could be both. So, for instance, like on an MMPI. So the 4 scale is an indicator of antisocial tendencies. And when I say antisocial, I don't mean
don't want to talk to people.
I don't mean isolative, right? I mean against social norms.
Yeah, so
right?
like kind of psychopathy, criminal behavior.
Right, but it can also just be like not loving authority, right? And there's different based on the elevation. And then a 9 scale, which is generally speaking sort of energy, right? If you have a lot of energy and you're very antisocial, right, you may be more likely to fit a narcissistic profile, right? So that would be on the MMPI, whereas the Milan has specific scales based on person. So they do have one that's tailored to narcissism or tailored to more borderline personality.
How accurate do you think these things are?
Well, it depends. It depends on the elevation, right? If it's an extremely elevated profile that's pretty set in stone, it's going to be more accurate to apply that diagnosis to it, because that means that they checked off more boxes in terms of those criteria.
Is it binary? Because like when you look at, some of those questions seem kind of crazy. Yeah. Well, because a lot of them are yes/no questions, right?
Those are forced choice. However, in the MMPI, there's 567 questions. So within that 567 questions of forced choice, yes or no, you tend to find those patterns emerge much more, because it's on a certain scale. How many times did you answer one direction or the other?
For the MMPI and like those, how much of it is this question correlates to, let's say, this scale? Like this question is an indicator versus like the pattern of questions. Like someone who answers like these 5 questions, 10 questions in this pattern, right? Or like looking at the bigger picture of the patterns versus like, hey, this is a depression question. I know some, Yeah,
so for both like the MMPI and the Milan, there are these high level scales. And there's twofold, which we didn't even talk about. One of the things that makes like the MMPI a brilliant test is that it's just as good as assessing what was your approach to the test as it is what your findings were. So did you have a tendency to maybe be more defensive, or you or the opposite, maybe in such a degree of distress that you're amplifying symptoms? Did you get fatigued at the back? Were there random responses? So having those indicators can be strong. But kind of directly to your point, so there's the scales, the real high level scales, which were built by kind of factor analysis. There are then 4 or 5, kind of subscales within that that correspond to that, and then there's questions which loaded into those scales. And then beyond that, when you get a score report, you get kind of critical items, right? So if someone said, I often think about ending my life, that's a critical item, right? Or there are, kind of different categories of critical items like anxiety, acute anxiety state, or, a few different facets, without getting too specific about what the tests look like, that are areas to look at. I think it would be dangerous to look at one question and say this person has that diagnosis, just as it would be dangerous to give someone an MMPI and say that they have that diagnosis. It's always used in correspondence with other tests, with a diagnostic interview, with collateral information, with talking to their other providers to come up with the best picture of what's going on.
Yeah, so it's not just based on the test, it's based on your interview and experience and that kind of thing with the client. So you could factor all those things in to try to get the best conceptualization, and at the end of the day, right, it's just like what's the best path forward. Because don't some of the psych testing like give recommendations of this person would do well with this kind of therapeutic approach versus this one?
Well, some of the tests do. At this point, like it can. If you buy, so for instance on the MMPI, there's different reports that you can purchase, different models. I don't ever do an interpretive, or
you don't do any of the interpretive.
I do the interpretation myself. But there are suggestions there that say, someone with a profile with these code types, these specific elevations might be more responsive to, say, group therapy or individual therapy, or different more specific interventions. It also indicates prognosis sometimes too. So if you're more it's a prognosis, the likelihood of success. And so if you're really, really high on an antisocial scale and you don't want to be in therapy, if you were like externally referred by an employer for an assessment, say, your prognosis might be weaker because you're going to be less likely to adhere to treatment recommendations. So those things kind of factor into it too.
Where do you factor in? This is a lot of interest people have on here too. Kind of the attachment theory. Do you use that lens at all when you're working with clients, or is that something that you look at?
Well, absolutely. Looking at, particularly when it comes to relationships, how does the experience that someone is having in their current relationships, what is that bringing up in them? Right, if that's experiences of anxiety or ambiguity or distance or whatever, applying to the multitude of different attachment lenses, and then we bring it back. Let's explore what does this relationship that you're currently experiencing bring up in you, and what does that remind you of? Right, what were other experiences that you had when you were younger that may have kind of brought about some of these emotions that you're currently experiencing, and oftentimes it brings us back to early caregivers, early experiences. It can be traumatic experiences that kind of emerge some of these attachment styles.
Do you find that people who like, let's say, either seek services or folks who let's say had a crisis emerge, I don't know, like just say the people we see more are folks who are more in the anxious, preoccupied, or disorganized. Because I see that too with followers, like people who are interested in mental health, who struggle the most, who seem to be most engaged and maybe more engaged in seeking therapy or being referred into therapy services by other professionals, let's say, are more anxious, disorganized attachment. That's
interesting. I've not thought about that. Initially, when you brought up the question about who seeks services, it brought up just to me kind of the concept of privilege, that the more likely you are to have good health insurance and resources and time in order to kind of address these concerns, the more likely you are to have help-seeking behaviors to kind of move in that direction.
Interesting.
I've not so much thought about it in terms of attachment style. That said, I guess it would make sense from a conceptual perspective that if you're experiencing kind of more, well, it's tough to say, right? Because I think somebody with an anxious attachment style can also be kind of more avoidant in nature sometimes too, and maybe be less likely to seek out some of those responses.
And I noticed too, like some of the clients who have like the most logical, I think some of the ones that get stigmatized as narcissistic, a lot of the dismissive attachment, because we have so many people who are engaging in services or even interested in mental health, right? And they tend to be more on like the more preoccupied scale. And then you have the folks that kind of fit this more like dismissive, hyperlogical, avoidant, right? And they do it for their own trauma reasons, because let's say even if you're secure, maybe you tend in a direction, just like another mental health disorder, was like stress plus vulnerability or your personality. And I joke that I have a lot of fun working with those folks because a lot of times they come because of a crisis, right? Maybe even someone with like narcissism, they come from a crisis. Their employer, they got caught cheating, and they're a little bit reluctant. But then sometimes if you could appeal to their more logical side, then they start to realize the importance of being in their emotions and vulnerability and exposing themselves to more emotions. But you just don't see them as much, I guess. I don't know. That's just been my experience.
Well, and that goes back to that. I think sort of the theory I had earlier that, it might be slightly more adaptive to sometimes have narcissistic traits than it would be to have borderline personality traits. And so you might be more likely to see someone present with the symptoms of borderline personality disorder, even if the prevalence isn't all that different. Yeah,
I think for borderlines, like some of the symptoms are adaptive, but some are like vulnerabilities, like where it's like substance use. It's like, as I view like with borderline personality, it's like I always view it as like you have a fin or a filter with holes in it from your emotional world to your present world and your conscious world. So it's like, something in your environment can trigger, maybe it's something with attachment or validation or just something that you're more sensitive to, and then it's like a fire, and it takes over, and this emotional reactivity, and then the substance use and some of these other things are meant to put out that fire.
Yeah.
Whereas like with narcissism, right, you create this bubble, this shell, this hard layer between, and they're like just as sensitive on the inside, but they're so disconnected from it.
Well, their coping skills are different. And
it's a lot of it's for the same thing.
Adaptive, right? Is that it might be more functional within society, even if the symptoms that present as narcissism or as borderline personality disorder were adaptations so that individuals could kind of get their needs met in their life at that time.
Sure. So, do you watch Harry Potter? Are you a fan of Harry Potter?
I've seen Harry Potter, yes.
Okay. So
read Harry Potter, seen Harry Potter.
So that's another one is getting back to the pop psychology that I think people. So I did a video yesterday joking, and I did one a while ago, and it did okay, but like finding like the convergence between people's identity with their houses.
Yeah.
And from like a therapeutic standpoint.
Sure.
And I did this, like I did a couple of these, like joke, like where a therapist just asks someone their Hogwarts house, and then they just like kind of nail them to the wall with their personnel, and they're just like, oh, and it's going gangbusters. Like people, and I mean, people love Harry Potter. And when I originally started, and I did a YouTube video like about this, about what does your house say about you from like a clinical standpoint. And I did like a little research beforehand, and there are people who've actually done like peer-reviewed literature in journals about looking at psychometric and like looking at are there patterns between people who identify with certain Hogwarts houses and personality and other clinical and it's out there. And there are some actual like parallels to be drawn there too.
I would totally agree. And just this is one that I have taken. I think I took it twice. And the first one, of course, I don't know where it was. Some online quiz. I was like in the middle. I was not in a house. I was not even placed.
You're like between two, or
I was between all four. Right.
Oh, really?
Yeah. I think the second time I did it, I was at Gryffindor, and maybe you can tell me what that means. But again, with this, I think what can be fascinating, and what probably is, I think what could be dangerous about this is that. And I would be careful about this because people obviously really resonate with it. But when individuals in a harder science, say like a medical field, are trying to, if we're sort of trying to fit within that model so that we can get compensation for treatment, so that there can be parity between mental health and physical symptoms, when our interventions are what Hogwarts house are you in it, people laugh at us, and so I think the take care of what does from an intervention standpoint, what do you resonate about this? Why is it meaningful for you to find connection with this kind of this this group of, kind of identity factors that might, contribute to your Hogwarts house. However, please don't define your personality based on that.
Yeah, and so everyone knows we don't actually do this in the field. I just do it on TikTok, but we don't do it in the field.
And it's just, let it be a facet that helps inform who you know that you are and to resonate with. But I'd just be dangerous to suggest that, this is who you are because you fit within this Hogwarts house based on this online quiz that someone created to get some advertising money. So I hope I didn't alienate too many people with that statement.
Yeah, no, I don't think. Yeah, I think people they take it seriously, but not that seriously. Or they identify with it. And I think I think there was some kind of brilliance to what she did with like these kind of archetypal, her own like archetypal personalities that people identify with. And when I've done videos about this, and people are like literally all the things are like, God damn, you just called me out. Like, thanks a lot. Like you just nailed. And like. And of course, it's just based on, it's like, so it's like...
Some people will resonate more than others.
Yeah, and some people are quick to go on the comments and be like, you're an idiot, like, you're wrong, but it's just kind of funny how many people resonate, and sometimes it's just, and TikTok's like kind of its own, the way like the algorithm works, and it's like, and how advanced some of these things are, how it pushes the certain people who are interested. And then it's interesting, too, to just read the comments, and I've actually learned a lot from posting on TikTok on certain topics, because people in the comments will tell you their experience. So I've actually learned a lot, like where you start to see patterns in people's experience, not necessarily with Hogwarts, but, with anything. And then too, like the way I've done it with those posts is like I'll look at, okay, what are the traits, right? And then I could think of like, okay, here's a client, or here are clients who present with, let's say, that are more emotional, they're more giving, higher, like more empathetic, right? And say, okay, well, hey, this reminds me of someone who struggles with codependency, right? So, so I'll say that, and then people who identify are like, oh, yeah, totally.
Which is exactly true. You're now using that language to help someone maybe resonate a little bit more and help broaden their understanding of who they are in their experience. And I think for that, these are really effective tools.
For sure,
It's a therapeutic intervention of self-discovery. So.
Yeah, for sure. So well, I thought maybe if anybody has some final questions for Dr. Brent, the topic is diagnosing. We're talking about personality disorders, which you all love, but how do we diagnose? What are more advanced diagnostics? What are the implications, the strengths and weaknesses, limitations of diagnosing? How is it done? Why is it done? So if any of you have questions here before Brent heads out to enjoy the rest of his Sunday.
I saw the one comment that said, spoken like a guy who's between houses, and I appreciate it. Yeah.
Come on, we want a definitive answer, okay? We want to put you into a box. That's what we do. We want to know your diagnosis. We want to know.
Which I think is us being uncomfortable with ambiguity, which is a problem.
Exactly. Okay, so what about, and this is, I think, a question that we as folks in the mental health profession, especially therapists, get all the time, not to mention in dating scenarios, but are you analyzing me? For someone who's so like diagnostically inclined, like what does that look like in your personal life? Like having all this, you can't unknow it, but how do you approach that in your interpersonal interactions?
Yeah, well, it's twofold, and I think my counter argument when people are like, oh, are you playing therapist right now, is that, well, maybe I became a therapist because that's how my mind works. That like I sort of notice some of these things and I want, and so I'm doing that in this particular setting as a friend. And where it can be really dangerous is when you start to explore like, what does this mean diagnostically, or what does this mean in terms of more clinical information?
Disorder.
So to answer your question, am I analyzing you? I feel like all of us are always analyzing each other anyway. And that's not necessarily something true of a therapist, but that's just how we work, right? We're sort of trying to find connections and resonate with people and
patterns, and putting people in boxes, like we just said, because that's our way. I think as humans, that's how we understand the world, is through patterns. And
the goal, in many ways, is to sort of separate that in a way that we can become more comfortable with. Can I actually just be kind of present and mindful and experience this person in the moment? But that's kind of how we're always working, right? But the more we move towards being present, I think, is the less of that exists. So
Jackie says here, I'm sorry if that's not actually your name, but we're going to call you Jackie. That's pretty funny. She says, I imagine a party of therapists would be so meta.
It's not.
Maybe what about like maybe philosophers? Yeah, if you got a bunch of philosophers together.
Yeah. As it turns out, when I leave my office, I'm actually kind of ready to not be a therapist for the rest of the day.
And when people ask me the question, this is what I tell them. I say, no, when I get off, I turn that off. I'm not going around analyzing people. But if there's a big red flag that pops up, then I'm like, oh, okay. Right. If it's like a blaring...
I think it's... Those things maybe stick out, but it's definitely having professional boundaries as to sort of, like, that's not my role in this situation. But also, too, I'm like... It takes a lot of energy to be fully present and engaged with someone in psychotherapy. I'm not doing that with my day-to-day interactions. It's a different way of being. Yeah.
Okay, and anywhere in your personal life, has this ever happened to you where you like have a friend or acquaintance that's struggling with something, and I mean it's like maybe very obviously depression or just something that you notice, but like let's just say they're like, I don't know why I keep struggling, or like where you just kind of cross that line a little bit, be like, hey, here are some things that I'm seeing. Maybe you want to get assessed for this, or like autism or like ADHD, or some like where you feel like it would actually be a benefit to break that bubble a little bit?
Yeah, well, I think the key boundary is that sounds like you're struggling. Maybe you want to go get this looked at.
Yeah.
It's very different than you are experiencing this, right? Because that's me diagnosing someone in in an informal setting where our boundaries don't exist, where we have a dual relationship. But as opposed to like, I think people do that, in a lay setting too. Like, sounds like you're really struggling. What are the things that you could do to get this looked at, or are there? Or sometimes I can take a slightly more professional role and say like, there's a lot of stuff that can be done about what you're experiencing. Maybe you want to go talk to someone about this. So.
Yeah. I mean, it reminds me a little bit like how we interact with like the psychiatry field a little bit too, like where we're and we should know more about psychiatric medications and the efficacy and like what different ones do, but we can't say you should get on this med, right? It's like, hey, maybe you should talk to your, like a commercial, like maybe you should talk to your doctor about propranolol for your anxiety, or Prozac for your nightmares, and antidepressants, right? It kind of has a similar feel where we want to stay within our scope of practice, but also stay within our ethical framework and boundaries.
Yeah, the same idea behind it is just having boundaries.
Yep.
You have different boundaries based on the role that you are playing, and when I do an eval, one of my recommendations is give diagnoses, and if I think medication's a good idea, I say go talk with your prescriber, or maybe seek out a psychiatric professional regarding what medications they may find it appropriate to address symptoms of X, Y, and Z. And that is how I kind of maintain balance in that setting. If I have a little bit more of a close relationship with the provider, I may recommend a little bit more. I'll have them sign a release and then we can have a conversation about it. But ultimately, it's up to them because it's their role. Right?
Okay, someone asked, do friends or family come to you for help?
Yes. Maybe not as often as you would think, right? And maybe that's because I am a different person in a different role. The person I present with, in psychotherapy, or the way that I am, is different than the way that I am outside. But I think I mentioned earlier, I was going to be a lawyer, right? And people didn't want to go to me advice for that reason too. So it depends on the relationship that you have with someone. So I mean, the answer is yes, and there are certain people that I don't think they would ever come to me for advice. Because they still think of me as 16 or whatever it was, and then there are other individuals who have known me during this phase of my life where this is something that I'm doing, and I think they'd probably be more likely to go in that direction.
For sure.
Or they've gotten to know me more so at that period of time. So.
Yeah, right on. Yeah, I would totally agree. And I think especially with addiction too, I know like both of us work a lot in that realm, and and I know for myself personally, and I've been open about that, where I've had my own struggles and engaged in the recovery community outside of work. It just, so many people reach out, and I think that's okay, and it makes sense of like, hey, well, what's a good treatment center? What should I do in this situation? Just like you would have a friend, it's like a hairstylist, what should I do? Maybe not for me, but for other people. So I think that makes a lot of sense. Well, oh my God, we just jumped up to 40 people in here. Maybe one more question for Dr. Brent. We could send him on his way and we could see what comes up. But yeah, what do you got going on the rest of the day? What does a doctor of psych do on a Sunday?
I'm going to have some leftover steak tacos, and I'm going to write a report for an evaluation. That's for a feedback session.
Brent's a really good cook. I credit myself a little bit for that, but what's out of battery here? What is a good book? What is a book recommendation?
I'll give you two.
Okay.
So in terms of like general, simple, something that people can read, kind of, a lot of these fall into self-help categories, right, or pop psych or whatever it may be. But the Four Agreements is a really good one. In terms of like, I just a little lost. How can I kind of explore myself a little bit?
It's an interesting book. Yeah.
Just briefly talk about wizards, but you get over that. But it's a Harry Potter thing. Everyone loves it. But it's just kind of 4 different categories of what are some things to live by that might make you a little bit happier if you do. So that's a good one.
It's an easy read too. Right? It's
very
not short.
Yeah, it's like
not
more like a pamphlet.
Yeah, it's almost like almost like poetic and versus like so that's an interesting one.
And then another one that I read recently is it's called Things Might Go Terribly, Horribly Wrong. By a psychologist named Kelly Wilson, who was one of the founders of Acceptance and Commitment Therapy, which I spoke about earlier. And it is it's basically it's acceptance and commitment therapy for anxiety, and it explores what is the what is the functional evolutionary role of anxiety, which is like if you got freaked out because you saw a lion by the watering hole, a million years ago, it made sense that something came up in you that said I shouldn't go to the watering hole, right? Like what function does it have in your life? At what point does it become kind of a problem? How can you kind of address it and continue to live a life that's worth living? So I'd recommend those books.
Monumental says Man's Search for Meaning is great. And that's one I recommend a lot too.
It's by Frankl, and that it goes from this existential standpoint. It's more in terms of searching, which I think is really meaningful. Trying to find what is important to you and can you live a life that's in accordance with your values. So.
Yeah, and that's one of the things, and I've done posts about this too, but I think it's like an intangible, I don't say it's intangible, but it's a variable that we don't talk about that often, of defining or like what is your purpose. And that was his argument. I mean, he had this whole like therapeutic technique that he employed. I think he called it logotherapy, of like finding your purpose. But it's just so important for getting through a hard time, like mental health disorder, getting over. It's like, what is the purpose of my suffering? What is on the other? What do I have to look forward to? How can I take this suffering and make something meaningful out of it? And that could just be a huge difference in just the way you think about things and just be overall happier, right?
Well, I think suffering is a teaching experience. What does this experience of pain teach you about what's important to you? If you're feeling extreme guilt because you lied or there's infidelity in a relationship, well, it tells you that being honest and truthful and faithful is important, right? And going in that direction. Or if your experience of depression or low mood is overwhelming, well, it tells you that you'd like some experience of relief from that, or that experiencing comfort and peace is something that's important to you. And what are the things that can move you in that direction? So. Well, I just wanted to say, Evan, it's been a pleasure being a part of this. Hopefully we can do it again in the future.
Absolutely.
Thank you so much to everyone that's been tuning in as well and asking these wonderful questions.
Yeah, we had an awesome audience here, and everyone was super engaged, and I'm sure they appreciated it. And we'll definitely have you back on the show, as we'll now call it here. All right, man. Thank you so much. Take care.
Yeah, all the best.
Dr. Brent, ladies and gentlemen. Man, the myth, the legend. Oh, we forgot to have him sing. Next time, we'll have him sing. But yeah, y'all, that's awesome. So yeah, just a couple of reminders before we pop out. I would encourage anybody, if you want, to send me an email, evan@evanthecounselor.com. If you can't remember that, go ahead and shoot me a message on Instagram with your email. We'll send you a copy of the book I'm working on, The Guide to Dealing with Difficult People. So you'll get a sample copy of that. You could sign up on my Patreon for a bunch of other benefits, and you get a free copy of the book at any level, and any updates I do, you'll get those sent out as well. All right, so my sponsor Vibe Interiors. Okay, so you've seen some of my videos. I got that really cool bowl canvas. Artista Fernando Vieira, he's the artist. And they just sent me today, I got a new piece from them. So I'm super excited. So for my office, it's a gorgeous canvas. That one on their site is called Fire Dance. So you should go to Vibe Interior, check that out. Yeah, I could sing our way out of here. You got to give me a recommendation. But yeah, be sure to check out my videos, comment, like, share, follow. Please check out my YouTube, give that a little bit of love. I have some more in-depth produced content on there, so you should definitely check out my YouTube. But for those of you who've stuck by, some of you have been here the whole time, a whole couple hours, it's amazing. Yeah. All right, so I think we'll tune out on that. I am going to peace out of the podcast. We will see you next time.